Well, it's a pleasure to be here. Yeah, I mean, it's Joy, and thank you, Joy and Jennifer, for hosting me, having me in the Evans Lab as well. I'm here to talk about experiences implementing rigorous program evaluations with the Measure Evaluation Project. I've taken a bit of a historical perspective. We'll see how that works. I am the Director for Evaluation on the project. Let's start with a little bit about Measure Evaluation. So Measure Evaluation is a global 5-year cooperative agreement with the United States Agency for International Development. So USAID is the United States' vehicle for aiding developing countries in all areas, not just global health. And we're a 5-year project. We have a $180 million ceiling, but expecting a ceiling increase. So we're a very large project. And the ceiling just means that caps the amount of money that we can actually take in over the course of the 5 years. We are in year 4 of 5, so we've already finished 3 years and are looking to try to already figure out how to wrap up. So it's 5 years goes by really fast. We are led by UNC, so I am employed by UNC. I work 100% on the Measure Evaluation Project. Projects this large are a little bit different than often what you would see at universities where researchers might have, or professors might have 2 or 3 grants going at a time. This one employs a lot of people at 100% time. And then we also have 5 partners, Tulane University, John Snow, Palladium, ICF International, and Management Sciences for Health. We actually have people who are co-located here in Chapel Hill from all those organizations, and we work very closely with all of our partners to implement the project. The project's strategic objective is to strengthen capacity in developing countries to gather, interpret, and use data to improve health. This is just a picture to give you an idea of our global footprint. It's completely inaccurate right now, but I haven't got an updated slide. But the main take home is that we are a global project, and that most of our work is in sub-Saharan Africa. And we receive funds from USAID, so it's all USAID funded, and we get funds from Washington, which is what we call CORE, which is what you're seeing up on the slide, and field funds, which are funds that would come from the USAID missions in country. So for this phase of the project, we have 4 results that dominate our world. So these are the things that we're implementing activities, trying to work toward achieving these results on a day-to-day basis. The first one is strengthen collection, analysis, and use of routine health data. So these are data that are largely collected at the facility level, but might contain community health data, client records. It's a lot what's used for reporting up to understand what's going on. We have a second result, which is improved country capacity to manage health information systems. So this is a broader result focused on developing the capacity in countries to strengthen the health system, the health information system, health information system being that, that covering all of the data sources, all of the government's management tools, trainings, everything. It's a system, so it encompasses a lot of activities that go on. And the data sources can run anywhere from surveillance, the routine systems, as I mentioned, special studies, surveys. So it's all about how those data come together in a country to help a country achieve its strategic objectives. We also do a lot of work in developing methods, tools, and approaches to address health information challenges and gaps. And then finally, and it's certainly not least, because it's what I'm going to focus on most of the talk today, is our result related to increased capacity for rigorous evaluation. I wanted to spend a second, just because I don't know the audience very well, just to make sure we're all understanding what we're talking about. What is rigorous evaluation? Okay, so we define rigorous evaluation quite broadly, and it basically is a research question that is defined and follows a specific protocol. So the methods, the design and methods are there to help answer the research question. It uses scientifically recognized methods. It clearly addresses assumptions about the design and threats to findings. It follows scientific standards and ethical procedures. Of course, we want the results to be shared and used, ultimately. And it can include outcome evaluations, process evaluations, economic evaluations, and of course, impact evaluation. And I just wanted to make sure that that you were aware that it is a broad range of evaluations that we do. Where impact evaluation might be, if you think of it on a continuum, at the one side of the continuum being sort of the very resource intensive, most rigorous, I will not use the term gold standard, but that's sometimes what it's referred to, where you have a before and after. Usually you're randomizing from intervention into control groups or comparison groups, and you're measuring what happens with the program and without a program, and that's usually termed a counterfactual. So an impact evaluation being sort of the most rigorous, I guess, if you want to put it that way, is also the type of an evaluation that we do. Okay, so I'm going to shift gears. That's a little bit of an overview of the project that we're doing now. So I'm going to go back in time and take you through some of the history of the project. The project is very influenced by developments and things going on globally within the government, at USAID. Different trends definitely influence what they asked us to do. So, and measure evaluation is in phase 4, so there's a lot of time that has come before this. I have not been with the project since 1991. I'm not that old yet. The first project was the evaluation project, and this was a project focused on family planning program evaluation. Okay, so we started out as an evaluation project. And then in 1997 to 2003, the scope started to broaden. We included other health areas, so not just family planning, HIV, tuberculosis, and started to focus on capacity building for monitoring and evaluation. We have had and continue to have a large network of universities that we work with across the globe, and that started in this second phase. But who knows what happened in 2003 that dramatically altered the course of global health? What happened in 2003?
They did something else.
PEPFAR. Okay, so PEPFAR happened and everything has changed. So PEPFAR was passed, the first round was passed in 2003, and that has really affected a lot of the work that we do. So what then happened in phase 2? So in measure evaluation phase 2, right after PEPFAR was passed, things dramatically changed from evaluation to focusing on indicator development and monitoring systems. We spent a lot of time training people, training PEPFAR staff on monitoring and evaluation, developing indicators. You may remember at the time that it was a lot of counting. It was a lot of number of people tested, number of people given condoms, number of people given abstinence programs, remember? And this was all, PEPFAR was an emergency, the president's emergency plan for AIDS relief, so things were moving very quickly. There was a lot of accountability needed at Congress about what was going on. So we were very heavily involved in the monitoring of those programs. From 2008 to 2014, it's measure evaluation phase 3. This is actually when I started in the project early in 2009. And things now at this point, there's a lot more capacity in countries for monitoring and evaluation. There's more data, systems are working better. It's all relative, but things are moving along at this point. So our work turned more to focus on improving the quality of the data and making sure that the data that were there were getting used. So are the data getting used at the program level? Are they getting used to are they helping managers do their job better at a district level, or are they informing national strategic planning? So we move a lot more into data use. Still, you're not seeing a ton of evaluation going on in the project yet. We were still focused on bread and butter monitoring and evaluation systems. But then I'm going to take a minute to step back and talk about some developments going on at the same period, that are going on at the same period when we're working on a lot of this monitoring and evaluation and data use. So there was a report, the Center for Global Development put out a report in 2006 titled, "When Will We Ever Learn?" And this was a report commissioned by the Gates Foundation that was working to understand why there was so little work in countries to rigorously evaluate, and specifically they're looking at impact evaluations, rigorously evaluate health programs to build up an evidence base for the programs that are going forward. That report came out in 2006. We found it to be quite compelling, and we point to it a lot. One of the authors of that report, Ruth Levine, went to USAID at that time and was part of the group that established the Bureau for Policy Planning and Learning at USAID. So this was established in 2010. There's a unit within the Bureau for Policy Planning and Learning called the LER, Learning Evaluation and Research Unit. I can't remember if it was a bureau or a division or how it worked. And this was a new bureau in USAID focused on building learning at USAID, building systems for learning. It wasn't there before, so things are changing at USAID. They issued the USAID evaluation policy in 2011. There wasn't one before. The USAID evaluation policy focused on impact evaluations and performance evaluations, where performance evaluations were broadly defined as containing a lot of any type of evaluation process, outcome, that type of thing. And this changes then how the missions are functioning. All of a sudden the missions are required to start commissioning evaluations on certain projects that have a particular funding level. And we start seeing more evaluations coming into measure evaluation, where the missions, the field missions, so at a country level, are asking us to evaluate their health programs. Of course, then in 2012 and 2013, respectively, the Government Accountability Office and the Institute issued some observations about the lack of evidence of informing PEPFAR programs. So the HIV programs that are being implemented, there was critiques that they were not evidence-based. Similarly, then in 2013, the Institute of Medicine issued the PEPFAR evaluation and had similar findings. And then in response, PEPFAR developed their evaluation standards of practice, which draws on a lot of evaluation policies from across the government. So we're seeing in the background, you probably lost me where I am, we're still back in the period of 2008, 2014. All of this is going on, and there's a clear swing back toward favorability for evaluations. So the next phase of measure evaluation started in 2014. This is the phase that we're in now, and we see a very dramatic shift in what we're being asked to do for USAID. We're much more focused on health information systems, so not just monitoring and evaluation, but the entire systems generating that evidence to be able to monitor and evaluate programs, and evaluation. So we've gone from maybe 5 evaluations in 2008 to 30 now. And we use a broad term for evaluation. Some of these are outcome studies, some of them are impact evaluations. And so there's been a big shift back toward evaluation in this current phase. So I'm gonna stop the history line and sort of come to where we are today, and talk a little bit about our experiences with evaluations, so that you can sort of understand a lot of the, lessons learned from over the course of the period. So we work largely, as I mentioned, in sub-Saharan Africa, and so therefore experience a lot of these real-world challenges. It's difficult to find comparison groups, for example. A program may be rolling out, but then somehow goes into another county that you didn't know about, and your comparison group is contaminated. Or there's another donor funding a similar program in the county you didn't know about it. Non-random placement of interventions is not a trivial problem. I mean, health programs should be going to where the need is greatest. That means that there are not necessarily areas where there is an adequate comparison group. A lot of programs function without a program theory, or at least not without one that's written down and articulated and thought through. So I have my health program, I have certain ideas about why it's going to affect health. Let's walk through that and think about, well, we need to do these certain activities. We expect those to change behavior, which is going to change health. So really being very systematic in documenting the program theory has been a gap. And then I hope you all know, or maybe you're in the process of learning, that if you have a well-articulated program theory, it also helps you identify the indicators that you might need to monitor program progress. It would help identify questions that you might have about the effectiveness of your program on an outcome. So it's useful in terms of guiding you through that process. Now that we've had some of the flip side problem, which is we have complex interventions with these long causal pathways. So an example is a study in Nepal that we just finished recently, where the government of Nepal was actively integrating gender equality and social inclusion into these community groups that are designed to support the health facility. So we were evaluating the effect of the inclusion of these gender equality activities in this health community on service delivery outcomes. So that just takes a long time. It has a long way to go to have to affect health outcomes. And well, at this point, we're looking at service delivery outcomes. So like, did more women use antenatal care? Did the child get vaccinated? So that can make it very complicated to study. It can also make it very complicated to understand the effects. And so we got mixed results, and fortunately there was a qualitative component which really helped identify like why we saw the results that we did. That leads me to this notion of time to impact. So sometimes programs or policy changes just have a long time to actually achieve a health impact that is desirable. And donors largely are pretty impatient. They want to know things now. So sometimes a program will look like it didn't have an effect, but it may not have had enough time to generate an effect. We have, moving on to sort of the next bullet, we have experienced, so one of the sort of trends that we've seen over time is that people who commission evaluations are much more aware that the planning of the evaluation needs to start at the beginning, when the program is being designed or talked about or implemented, rather than just waiting until the end and saying, oh, it'd be great to have an evaluation, did that work? And so that is happening more and more. The problem is that it's often done after the program has already been designed. This is, again, remember, specific to sort of USAID projects. And so we still have a lot of conversations to be had about trying to understand where we can get a comparison group, for example, because the program has already been sort of thought through. Inadequate funding for contingencies. I have to put this in here because it's something that has held us up a lot, where we're working in these contexts and we may have a lot of really good information, we may do a lot of really good planning, but something can always come up. Even if it's outside of our control, like a government, like an election in Kenya, or something gone awry. But sometimes you get into the field and you realize that the beneficiary lists aren't actually there or aren't as complete as they thought they were or something like that. Sometimes you just can't, things are going to come up, but you don't know what it is exactly. And it's going to cost more money. It's going to take more time. At the same time, we're trying to be very cost conscious. The donor, we are USAID's client. They're giving us the money. We're doing this on their behalf. They want us to be very cost conscious. So there's a big tension in terms of being able to budget for studies adequately, not knowing that something's going to happen to make it cost more, but you don't know what. It's not a very easy thing to sell. I swear we're going to need the money. I just don't know why. And then incomplete program evaluation, obviously, incomplete program implementation. You can have a great program in design, but then if you don't actually have anybody going out and doing your supervision or some component, it can reduce the effectiveness of your intervention. And I mentioned at the beginning that we do a lot of capacity building. So our result is capacity building for rigorous evaluation. So part and parcel of all of our evaluations is a capacity building component. We have an approach for assessing capacity and doing a capacity building plan and hopefully monitoring how capacity is changing over time. And we take a wide definition of capacity. And we have other ways of building capacity, like through some training and other activities that we have going on. And everybody is very supportive of building capacity. Missions are like, we tell missions, we have discussions, we're like, well, we are here to do evaluations, but our result is to build capacity for rigorous evaluations. So we need a capacity building component. And they're like, great, but we're not giving you any money. So there's a lot of will, but yet it's not necessarily backed up yet with the funding to really do it in a way that we would hope that it could be done. Okay. So I've brought you to the present and talked about sort of this trajectory of measure evaluation and how we started as an evaluation project, got back to being evaluation, and just some of the lessons that we've learned over time. So where are we going to go from here? I mean, we've got to stay ahead of the trends. Can't get too stagnant, or things are going to run over you. Well, this is what happened in 2017. In March, PEPFAR issues its communication to their missions. Although intended to optimize program implementation for impact evaluations have been costly, difficult to track, challenging to convert into strategies for improving programmatic outcomes. Yeah, okay, that was a bummer. We've got 30 studies going on, and all of a sudden they're like, we're not really interested anymore. And this is, this is what was the IOM report was 2013. This is 5 years after there being sort of a big report saying you need more evidence-based programming. So this is sort of what's coming. This is where we're heading. Is the pendulum is now swinging back away from being favorable toward evaluations. So this is going to influence our work going forward, probably will influence your work going forward, depending on how close or not you work in this area. PEPFAR's focus now, I shouldn't say now, because it always has been, but is increasingly on epidemic control. It's a very epidemiologic perspective that's going on. So they just issued a strategy for accelerating HIV/AIDS epidemic control, and in there it says how their approach is to continuously use granular epidemic and cost data to improve partner performance and increase program impact and effectiveness. Okay, I mean, it's good news. It's still very data driven, right? There's a lot of effort. There's a lot of perceived value of data. And you see cost in there. People are looking at costs as well. But it's very much looking at where is the epidemic and how do we affect it. So what is going on in terms of generating that evidence is sort of two main things. Implementing partners are using their data. So PEPFAR directly funds HIV programs in countries. The implementing partner is the term that we use to talk about those organizations that receive the money from PEPFAR to implement those programs. Some of them are local, non-governmental agencies, but a lot of them are international, non-governmental organizations like APAF or what would be another good one, ICAP at Columbia, for example. And so they have a lot of, they have their data. Sometimes it's integrated with the national system, a lot of times it's not. And they have their targets. PEPFAR is very target driven. So when you get money from PEPFAR to do an HIV program, there are targets. You have to reach this many people with HIV testing. You need to have this many people on treatment. So it's very target driven. And then they also have financial data, again, looking at costs. And there's a lot of use of this data to identify identify performance problems. So where of our facilities are they not getting enough people tested? Where are they not getting people on treatment? There's this something that's talked about a lot is the testing yield. So this is every time you go out and test people for HIV positive, what proportion you're testing positive. And you actually want to get a high proportion of people testing positive because that means you're getting new people who have not been reached with services before on treatment. And so the testing yield is very important. Another thing that's going on is the population-based HIV impact assessments, or FIAs. These are being implemented by ICAP, obviously with a lot of partners. These are household-based surveys. They have a lot of biomarkers in them. And the idea here is to monitor progress toward achievement of the PEPFAR goals, so the 90-90-90. 90% of people tested, 90% of people, those testing positive on treatment, and then 90% of those on treatment virally suppressed. And they're using that to monitor sort of success of those goals. And I will say as a note that in the new PEPFAR strategy, they're actually talking about 95-95-95 now for certain groups of countries. And they're also using this data, these surveys, to identify groups who need further effort to bring into programs. So young girls, for example, are being tested at lower rates, getting into treatment at lower rates, getting virally suppressed at lower rates. So they're using the data to try to identify at a country level who's most where the burden is falling. And I have an example here, and it's not really meant to be totally visible. And this is an example I took from from an implementing partner. So it's not our data at all. And what this shows, so this would be the partner's data of their project, okay? And it's an ART retention example, so 12-month ART retention, where what they've done is taken, and you see the dates are along the bottom, the time, and it's monthly. And you can see that they have demarcated a baseline period where they're showing where their project was implemented. So the green line is the 12-month ART retention, and you can see it's slowly increasing over time. The 75% is the median, and then these other pieces are interventions that they're doing to try to improve ART retention. So task shifting, for example. There's some new national guidelines implemented. They've done some data quality audits. And so, you see over time that they're slowly improving on their 12-month ART retention example. I mean, this is the data that they're collecting, and they're using it to try to understand their progress, and they're using it as some evidence that these are interventions that are working. This is very descriptive type of analysis that's being done. And these countries and these implementing partners are doing it, and they're doing some really interesting things. They're using it to identify, I mentioned, like low-performing sites. So they go, these sites are all meeting the testing yield. This site is not. We'll go out, find out why not, figure out what could be done differently, monitor that over time. Did the testing yield increase or not to the way we want it? And then there's conversely some stuff going on, which is like, well, these sites are really doing well, so let's figure out what's working well there and transfer it to another site, for example. So, I mean, but this is very basic root cause analysis that we've known about for, it's a strategy that people have been doing for years. The difference is now is that there's just so much more data, and the data is coming in more quickly. Sometimes it's coming in on a daily basis, like the partner can see on a daily basis because somebody might be using a mobile phone to talk about how many clients they reached that day. A weekly basis, at least a monthly basis. So that the ability to monitor and react and improve your programs has improved because of these technologies. There's a lot of very sophisticated looking dashboards that people have access to. Every time they boot up their computer, they can see the latest sort of success of their program. Okay, so I want to talk a little bit about how all is not lost in evaluation, however. Okay, so because of this sort of turn away from impact evaluations, and I will acknowledge, I mean, impact evaluations can often be very expensive. They can take a long time. They should be selectively used. Not everything needs, and not every question needs an impact evaluation. So some of the things that we have also been doing, I think, may now be received a little bit more favorably, given this move away from impact evaluations. I'm going to talk about the use of routine data and evaluations in complexity-aware methods. Just very briefly, we're getting sort of here toward the end of what I have. So use of routine program data and evaluation. So as I mentioned, the routine data are those facility registers, those client health records, aggregated reporting forms, resource records, for example. And this information can be used in evaluation. And there's actually a good paper out there and some good experiences. It definitely has pros and cons. So some of the cons are that even though there's been a lot of progress, there's still concerns about the data quality, the timeliness, completeness, reliability, and validity of those data. There are still a lot of vertical data systems, where the TB program has their own data collection forms, and the HIV program has their own data collection forms, and antenatal care is over here. And the data in those systems are not necessarily harmonized. Not that you would expect, necessarily HIV to be in TB, but even how they might capture pregnancy. Somebody might be capturing number of children birthed and number of pregnancies, and so when you try to merge them, they just don't line up. Availability of accurate denominators, so this would refer to if you wanted to create a proportion, like a proportion of women achieving their 4th antenatal care visit, you need the denominator from the community or the catchment area or the district or whatever it is, and oftentimes there's just not accurate denominators. They would come from a census, for example, or the data are old and the estimates may not be very valid. And then there's healthcare seeking behavior and or access. So people are not going to the health facilities, they don't have access to a community-based program and don't want to go. There's some reason, there's stigma, there's distance, you know, they're not necessarily being captured in these routine data. But there are several advantages. You have repeated monthly counts. So if you take some of the aggregated data from the facility, you can have data for month after month after month, and that allows you to do some survival analyses and things that are a little bit more sophisticated. I have census data here, and what I mean here is sometimes if you want to work, you can actually work like at a region level, you could even do national, like you could work with every single facility in the country, and therefore you have a census and it eliminates some of the statistical analyses that you have to do. The data are often easy to graph and understand. This is relative. I think there still is a capacity issue, but you know, you are often talking bar charts and correlations. You can analyze data at different levels of aggregation. So you can do client level, you can do facility level, you can do district level, you can do regional level. So you can get a different level of aggregation that way. You can identify a comparison group. You have a lot to choose from. So if you want to match districts, match facilities, so that also helps. You can also do that. You can also do some matching techniques to identify a comparison group. You can identify dose or intensity measures. So let's say you wanted to know about, you know, whether more frequent supervision visits results in improved, you know, use of hallucination, for example. Then you could try to capture that. And most of the time with the routine data, you're going to be more likely to be able to measure outputs and outcomes over impact. So you're going to get service delivery indicators. You know, did people receive services? But you're not going to know so much about health outcomes, like did maternal mortality or infant mortality decline. So here's an example for measure evaluation. My colleagues, Sean Curtis, who's at UNC, Stephanie Mellon, who's at JSI, and Zolfia Charieva, who's at Palladium, have done an impact evaluation of a project in Ukraine to strengthen tuberculosis control. It was an integrated HIV/TB program, and they did it was a mixed method study, but one of their primary methods was the client data, and they extracted data from the standardized TB and HIV forms in the medical records and measured time to ART initiation for the co-TB HIV infected patients. And there are some, they have completed the study. There are some good results. It hasn't been disseminated yet, but there are some lessons learned, still takeaways. So that even though they use the routine data, there's still a lot of costs associated with data collection. There still is a need to go in and abstract, and the data, there were a lot of problems with it. That there were still issues with data quality. There was a lot of cleaning of the data that were needed. I think, for example, they mentioned that a lot of the dates were wrong. And then, as I mentioned earlier, there were different variables in the two systems, so there took a lot of work to be able to merge them. And then the system changed over time. So this is a baseline post-test type of study, and over time, the system, the actual routine system they were using changed, and there were some technology changes that got integrated into, I guess in terms of TB detection, that got integrated into the forms that they didn't have before. So you got to sort of shift gears and move along with the system change. Okay. So just a note about complexity-aware methods. This is, so I think another sort of theme that's been coming out lately is this notion of complexity. And so you can be working in complex environments, you can have complex interventions, but the idea is that there are strategies to manage that complexity. And there are a number of different methods. Organizational network analysis is one of them. Outcome harvesting is one. And we've used most significant change quite a bit. It's a qualitative method, and the notion is to basically sit down and ask people, what do you think made the biggest difference? And then do some more systematic triaging to really help those outcomes, like what made the biggest changes, float to the top. And so I'm not going to go into details about this study because it's not one I was so close to, so I didn't want to say anything wrong about it. But it is a method that especially when you use it in combination with other quantitative methods, can really help you sort of triangulate what happened. Okay, so this is my last slide. So it just, you know, you want to do a presentation and have people take away a couple of messages, and these are mine. So like, just things just happen in our work as a pendulum. So I bet you a lot of money that in a few years you're going to see a lot more interest in evaluation. It's going to come back around, and we'll be ready. You know, I think it's okay that sometimes, you know, that this pendulum happens, this ebb and flow of what people are interested in. It pushes you to be more innovative. I mean, there are a lot of downsides, and hopefully, like the evaluations we have ongoing will keep going so that the investment isn't lost, for example. But you know, it does push you to think differently and really want to stay ahead of where the sort of external forces are pushing you. And then this last one is something that I didn't really focus on too much, but I think it's really important. Is that it's really your evaluation question that matters. It's not whether you want to do an impact evaluation or you really like the most significant change method. It's your question. Your question drives what method and what design you use. And so at the end of the day, that's what's really important, not just the fact that that there's all this. You got a lot of tools in your toolbox. And you got to apply them to answer your question. And I'm done. Thank you.